Hello everyone. I will be presenting today the first randomized controlled trial for multidisciplinary rehabilitation of survivors of war torture in a post-conflict setting. I would like to start this presentation by declaring on behalf of the research team that I have no conflicts of interest to declare. The study, a novel biopsychosocial approach for rehabilitation of traumatized victims of torture and war in the post-conflict context, a pilot randomized controlled trial in Kosovo, was conducted in collaboration between Dignity, Danish Institute Against Torture in Denmark, and Kosova Rehabilitation Center for Torture Victims in Kosovo. I am Ardiana Bytyçi, a psychologist and a project manager at KRCT for 5 years now. I was involved on implementation of this randomized controlled trial, and I will take you through the main points of its implementation as well as outcomes. Due to time limits, I will focus more on the outcomes, though the publication of this study is in progress and soon you may have access to it. We have used an epidemiological approach to study torture and organized violence in Kosovo. The first phase was conducted in 2008-2010. We were identified a number of 125 survivors of torture. I wasn't really involved in this phase of the study, though it's already published and the results may be found online. However, I was very much involved in the second phase of the study in 2012-2014, which is a randomized controlled trial, and the selection of participants was done based on the sample identified in the first phase. The inclusion criteria for participating in this study was not restricted to gender, though the eligible participants were those between ages 18 to 65, and they had to be survivors of massive violence from northern Kosovo who have reported one or more traumatic experiences such as torture, sexual harassment, arrest and detention, execution of family members, and so on. On top of this, the criteria was to be diagnosed with chronic pain and one of the disorders, post-traumatic stress disorder, depression, or anxiety disorders. We had also few exclusion criteria, which were based mainly on what we believed would affect the assessment outcomes. Therefore, here were excluded cases of mental retardation, schizophrenia, abuse with substances, psychosocial problems and personality disorders, as well as those who undergo chemotherapy. In addition, we have excluded also cases that have received cognitive behavior therapy in the past 3 years. So in general, we could reach 51 out of 125 survivors of war identified in the first phase, though not all of them were eligible for this type of intervention. Therefore, we have added 13 other clients from other KRCT projects. So in total, we had a number of 34 participants in the study, which were randomly assigned to one of the groups, experimental group or waiting list group. The intervention here was based on a biopsychosocial approach. We used a rehabilitation model developed in Denmark, though we have simplified and adapted for developing countries in a post-conflict setting. The major components of the treatment were biofeedback and cognitive behavior therapy based on the prolonged exposure therapy manual, on the adapted version of it. Also, it was another component which is group physiotherapy. On top of this, both groups, intervention and waiting list group, have received multivitamin pills. The intervention group received treatment plus multivitamins, while the waiting list group received only multivitamins while waiting for the treatment. Though more than 10 years after the war, most of the survivors have reported not only difficulties, mental health difficulties, but also socioeconomic difficulties. Therefore, we have used the biopsychosocial approach. On weekly basis, we have provided 10 individual therapy sessions of 90 minutes, 50 to 60 minutes of cognitive behavior therapy intervention based on the, as mentioned before, on the adapted version of prolonged exposure therapy manual. 20 minutes of breathing training by using biofeedback device, 10 to 15 minutes for reviewing and note-taking purpose. While homework was assigned at the beginning, it was canceled later on because it does not work in the developing country context, and it's a burden for not only for the client but also for the therapist who works. 10 group therapy sessions, physiotherapy sessions were also provided. 60 minutes group exercise to promote physical fitness, communication, social participation, and emotional well-being. 20 minutes of individual instruction for specific injury, location, and pain, while 5 to 10 minutes were given to pain management using TENS. Of course, multivitamin pills were provided once per day for 6 months, and KRCT was available for social support depending on requests. Before I start with more details on validity and internal consistency, I should mention that the monitoring process within this randomized controlled trial were unique among all rehabilitation centers worldwide, considering that they were consistent and continuous. And they included not only validity and internal consistency of the instrument, but also supervision, treatment compliance, quality assurance, training, and so on. As per validity and internal consistency, all the instruments, all the tools used in this study were validated in previous studies, while they were also tested for internal consistency, which resulted in a good one in this present study. Quality control processes were very important to the entire implementation of this randomized controlled trial. Despite organizing a one-week workshop and 2 refreshing courses, the therapists involved in the implementation of the treatment program had the opportunity to have a 2-hour weekly Skype supervision to address all implementation issues. On the other hand, it was organized also treatment compliance and quality assurance process where 15% of all treatment sessions were recorded and were reviewed by a independent CBT expert. As for the ethical approval and the consent to participate, we have to mention that the study was conducted in accordance with the Helsinki Declaration and the Danish guidelines issued by the Danish Data Protection Agency. Of course, the study was evaluated by Ethical Committee at Dignity, as well as was approved by Ethical Professional Board at Ministry of Health in Kosovo. All patients, all clients have signed informed consent for participation in the trial, as well as for recording their sessions. We will go through now the outcome measures, which were divided in 4 subtypes from biopsychosocial perspectives. We had emotional well-being, where were measured anger, hatred, aggressiveness, police or military phobia, inferiority complexity, and social inclusion. As for the mental health, it was measured PTSD, depression, and anxiety. For physical health was measured chronic pain, body mass index, hand grip strength, and standing balance. While for functioning and social outcomes, it was measured income, employment rate, and disability score. Mainly the clients engaged in this treatment program were of age 47.7, and 55% were men and 45% were women. Half of them have only primary education, and only 21.4% were in paid employment, All these data were from the baseline assessment. All of the participants included in this program had comorbid pain and at least one of the affective disorders, PTSD, depression, or anxiety. They were categorized as overweight, and both groups showed poor standing balance and hand grip strength at baseline. Considering that both groups were comparable regarding sociodemographic data, randomization seemed acceptable. The only difference was on the depression scores, which were worse for the intervention group. We will go now through functioning and social outcomes, and here should be highlighted that despite their mental health difficulties, it was crucial for torture survivors to engage in labor market and have employment opportunities. Therefore, throughout the course of treatment, employment rate increased for 15% for both groups, as well as the income increased for 47 to 137% for both groups. We have a slight reduction in the disability level measured through WHO disability assessment scale. Regarding physical health outcomes, BMI was not significant over the trial, though we have a significant improvement on grip strength in both hands and for both groups. Regarding physical health outcomes, we did not reach statistical significance regarding chronic pain. There was a wide variation among participants. Some had significant improvement while others did not. Therefore, we believe that this might lead to insignificant results in improvement. As for the emotional well-being outcomes, we have a reduction on anger and hatred, as well as for the aggressiveness for the treatment group, though it does not seem the case for the waiting list group. Regarding police or military phobia, we have inconsistent pattern, as it can be seen, and we believe that this might have happened due to the focus that it was given to police or military phobia, and which might have an effect on the perception of the clients, as well as we believe that it might be also the effects of short-term effects of prolonged exposure therapy. Here we have mental health outcomes, and we did not have a reduction on PTSD scores, depression, or anxiety. However, it should be mentioned that 1/3 of the PTSD clients were successfully treated throughout the course of the treatment program. Here we have the impact on continuous outcomes at 3 months, as well as the impact on continuous outcomes at 6 months. It should be mentioned that the follow-up at 3 months, we had a improvement on PTSD scores, anxiety scores, as well as disability level. Though, as it can be seen, the effects fade away at the 6-month follow-up. In general, there was little marked impact of intervention on the outcomes at 3-month follow-up, with the exception of pain and military police phobia, which were worsened in the intervention group. However, at 6-month follow-up, the negative impact of treatment on pain was no longer evident. There was little evidence of differences between the two groups, apart from PTSD scores, which were higher in the intervention groups. But generally speaking, at 3 months follow-up after the treatment, there was little difference between the two groups, intervention and waiting list group. What's really important is that there was slightly more remarkable improvement on social outcomes, physical strength, a feeling of anger, hatred, employment, and income, rather than on chronic pain and mental health condition. Here we will reflect on few issues that are really important to the study. There were no statistically significant effect on the mental health outcomes, although 1/3 of the PTSD clients were successfully treated, and also it was reported clinical improvement among the participants by therapists. We believe that the lack of significant effect was due to the size of the sample, due to the small size of the sample. Another issue that we should reflect on, that Here we should, in this type of intervention, we should take on consideration the complexity of the treatment and should include many components, not only physical and psychological, but also family and social factors. Therefore, we should have a multiple stakeholder perspective, not from only the perspective of the patient, but also of the provider and society in general. Furthermore, on this type of trials and this similar intervention, it is really important not only to use subjective measures, but also to be based on the objective outcome measures, such as employment, income, or physical strength. Finally, when aiming to achieve stable recovery of war and torture survivors, we should take into consideration also their social inclusion, which will improve the quality of life and, as a result, the mental health condition. At this part, I need to emphasize that it is highly important to establish a monitoring relation between data collectors and those who work in the field and who are responsible for the implementation of the procedure. Treatment integrity errors and data reliability errors can be avoided through maintaining such a relation. Finally, this study could have not been possible without hard work and efforts of a research team at Rehabilitation and Research Center for Torture Victims in Denmark, as well as field team at Kosova Rehabilitation Center for Torture Victims, including local consultants and external consultants as well. The publication of this study is in progress, and soon you may have access to it. Until then, if you have any questions, feedback or comments, please address to me, Ardiana Bytyçi, at KRCT in this presented email address, or to Charlene Wang at Danish Institute Against Torture. Thank you for your attention.